picture, this is the cardiac orifice of the stomach. Left side, the stomach is going open like this. So the cardiac orifice of stomach, maybe as per my previous something knowledge of the diagrams or of the things I have shared, this picture is something like this. So cardiac orifice more or less corresponds to this region. Exact location, 7 costal margin, 1 inch to the left. Okay. We obviously very clear and very frankly I want to tell you, all these correct things are not always essential. It's not easy to remember. But don't mistake the left thing as the right one. The cardiac orifice should be on the left, not the right. Okay? So the thing, the teacher who is observing, he is observing and counting the ribs. Under counting the ribs, suprasternal notch going downwards. This is the, I am feeling the sternal angle. Going to the, in this way, I am feeling the second rib. Second intercostal space, third rib, fourth rib, fifth rib, sixth rib, seventh rib, like this way. So in this region, close to this margin, I am having the just getting an idea. More or less this region I am having the cardiac orifice. But orifice, it should be something like this. No? So for better representation, if I put this point like this dot, obviously you will get marks. Full marks you will get. But for more appropriate surface marking, what we need to do? We need to do just 2 lines. Just 2 lines like this. Slightly to the left. So this is cardiac orifice of the stomach. Exact value, half inch apart, doesn't matter. This is just in Buddhist language. But the thing is that teacher will observe being on the left side. Teacher will observe you are counting the ribs, okay, and putting a point in 2 lines. Exact all these values, nothing that much important because we also don't remember, we also don't expect you to remember. Okay, but the thing important for us is having follow the correct procedure. So this is cardiac orifice. Pyloric orifice. Now pyloric orifice, before going to this, now where is pyloric orifice? The pyloric orifice, first we have to do a transpyloric plane. So what is the transpyloric plane? Lower border L1. So how do you do the surface marking of transpyloric plane? Very good. After each individual, same individual. Correct? Let me check his defined process. This is the defined process. You want to put it out. So more or less, this is the area of transpyloric plane. Okay? So I have drawn the transpyloric plane. What is the other technique of doing the transpyloric plane? Just observe. See, there is a depression. You see, there is a depression. This is the other technique. একটু চেষ্টা করে আরেকটা এইখানে দেখবেন you just observe there is some thing that is depression is present. Okay. So this is the tip of 9th costal cartilage. Okay. Tip of 9th costal cartilage corresponds with transpyloric plane. Okay. So this is another technique of knowing the transpyloric plane. So where is the my location? Second half inch to the right of midline. So thing is that Transpyloric plane slightly to the right. So more or less happy means slightly to the right in this region. So this is the midline. Transpyloric plane slightly to the mid, slightly to the right. So this is my area. Okay. So first I draw the transpyloric plane, then I am assuming a midline. Okay. Slightly to the right of the midline. This is half inch. Then again similarly, two lines. But what will be the direction of the line? Check this. It will be something like this. If you put a point also, it will not matter. But the thing that is matter in this case of pyloric orifice, whether you are drawing the transpyloric plane or not. Second thing, whether you are putting the point on the right side or not. Clear? That is important. So these two things are important. Whether you are instead of half inch, you may put it like that distance, but the distance also doesn't matter. Okay. The thing is that drawing of the transpyloric plane, putting it on the right side on the transpyloric plane. Clear? So all these things, let's go. Question? It's quite easy and it's very, very important in your whole life. You get a lot of pressure in your whole life. So, what I will try to do? Anterior superior spine and umbilicus. So what I am trying to do? I am trying to get it to my point. So this is the point I can feel the anterior superior spine. But whether you are pointing over here or here or here, again doesn't matter. But the thing, the technique matters. First you feel the iliac crest. You feel the softness of the abdomen, you feel the abdomen iliac crest. Then you go anteriorly. And you feel more or less in this region a point, anterior superior spine. The thing, whether you are pointing exact anterior superior spine is not important, I am repeating. But the technique is important. Whether you are doing it here, not important. And the thing, feeling the iliac crest going anteriorly and you feel the notch. So this is anterior superior spine and obviously this is umbilicus. So I am doing a line. Okay? What is this line called? Spino-umbilical line. Spine, anterior superior spine, umbilicus. Okay? So more or less, I divide this line into three parts. Like this, like this. So where will be my exact point? Three parts. More or less, I am dividing it into three parts. So this is the okay. So this is the area for McBurney's point. And McBurney's point is clinically important for yes, not appendix, acute appendicitis. Appendix is present in all of us. But when it will become tender, make the patient lie down, but he is just standing, but his abdominal muscle is rigid, bone is great. But if you place it over here, you don't feel the exact pressure. So what will the patient will be lying down, he flex the hip, flex the knee. So abdominal muscle will relax, turn the face of the patient on the other side. He or she will not see what you are doing. Just do like this. What we do in our clinics, just flip the point, just do this, like this, one point, just one place you do it. This is just clinics. Like this, you feel it. Then you just gossip with the patients. Okay, how you have eaten any food? Like this, you gossip with the patient. Just what you do, like this. Just to give patient in pain. If it is acute appendicitis. Okay, just clinical diagnosis, acute appendicitis. So this is what happens. From that point, you in your whole life. Apart from acute appendicitis, what you suspect in case of female patient? About this patient? Suppose a female patient also come to you with the same complaint. So what do you suspect?
Inguinal hernia.
Anything, any extra thing in this region in case
Hernia,
of
hernia, inguinal hernia.
Huh?
Inguinal.
No hernia, no hernia. Any extra organ in this region? If there is any ovarian problem, a cyst which is getting infected, a torsion cyst, a hemorrhagic cyst in the ovary, or anything problem in the fallopian tube may also mimic similar to on the right side acute appendicitis in case of female. Okay, so you should be very cautious with female patient because you are suspecting, supposing it clinically as acute appendicitis. Once you open the abdomen and see it's that the appendix is normal, but the problem lies in the ovary or in the fallopian tube. Okay. Also, there must be a case of ectopic pregnancy. Ectopic pregnancy may be present in the fallopian tube post surgery. So there may be also case of ectopic pregnancy. So in female patient, you have to be very, very cautious. Clear? Now, the next point is the highest point of iliac crest or the fourth lumbar spine. Now, how this is important? Anyone can give any idea to me? Daily to the OT, daily to the nursing homes, all cesarean section patients need to be done in procedure.
Anesthesia,
Lumbar puncture, very good, but not always. That's spinal anesthesia. I'm expecting not spinal anesthesia. Okay, lot of cesarean section going on, but not general anesthesia because general anesthesia is very hazardous. What we do? Working from below the umbilical level to the spinal anesthesia. Patient is conscious, no chance of any catastrophe also. Okay. So simple headache may be there. That is also a simple lumbar pain will be there. That is simple things. Okay, that is not major problem. So for that thing, you have to know some surface marking. So highest point of iliac crest is quite important in that respect. Lower border of the spinal cord in adult is at which level? Spinal cord. In my vertebral column there is spinal cord. Remember spinal cord? The lower border of the spinal cord goes up to L1 level. That is the key. We don't want to injure the spinal cord, but we are to introduce some anesthetic drugs below that level. So the key is that if I injure things, my needle, L1 level or above, then what will happen? Spinal cord will get injured, and my injury to spinal cord may lead to drastic consequences, like my whole nerve will get paralyzed. Okay, so I don't want that. I want a temporary paralysis or paralysis of some muscle sensation due to some anesthetic drugs, and that may be given via injection into a space or subarachnoid space present in this region in the cerebrospinal fluid. That is my target. So the key thing is that I don't want to injure the spinal cord which is present at the lower border of L1 level. So what I am going to do, the highest point of the iliac crest corresponds to, my knowledge is there, that the spinal cord in the vertebral column ends up to L1 level, something over here. I need to put my needle below that level. So how I will achieve it? Just my assumption will not make me 100% right. So I have to accurate, see, just not taking. I feel the softness, I feel the rigidity at first. Okay, more or less in this region corresponds to the highest points. I go to the other side, iliac point, go to the other side. Now what I'm trying to do again, I'm trying to meet these 2 points. Okay, check. So this point meeting the vertebral column with the spine in this region. What is the level of the spine? 4th lumbar spine. This is a point, go down. But why we need this point? Because we need to introduce my lumbar puncture needle below L4, L3, L2. So L3, L2, more or less this region, I will introduce my needle. Okay, the needle for what? For introduction of anesthetic drug for spinal anesthesia. Second thing, I draw the cerebrospinal fluid by drop is coming out, and that cerebrospinal fluid for testing of what? Diagnostic purpose, whether he is suffering from meningitis, encephalitis, or any tubercular meningitis, anything. So cerebrospinal fluid for histopathological examination for diagnostic purpose, you can draw in this way. Okay. So one is for introduction of needle for spinal anesthesia. Second one is for drawing of cerebrospinal fluid for diagnostic purpose. Suppose he is suffering from recurrent headache, some disorientation, some convulsion is there. Okay. So I suspect in tubercular or any meningitis or any encephalitis. So I need cerebrospinal fluid. So for that procedure I need 4th lumbar spine, and this one will help. And the plane that is we got in this region, the name of this plane is called Transcrestal Plane. Okay, Transcrestal Plane. Just feeling like this, 5 centimeters behind. Okay? One point. Second point also, I'm feeling like this with the spine slightly going behind. I'm feeling another point. Now, so this is what's called Transtubercular Plane. Now we do, this is clavicle, this is sternoclavicular joint, and this is over to this point. So what is the point is in this region. I am doing a vertical line. Okay. So this point is, this is the point for right or not right, it is iliocecal junction. And more or less 1 inch. 1 inch means my 2 fingers. Corresponds to 2 fingers right to the. This is the orifice for appendix. Okay. So this is the plane for Transtubercular Plane. This is the mid clavicular line, right lateral plane. This junction point is the iliocecal junction. 1 inch below is the appendicular orifice. So if you do again, you can see this point is the McBurney again. If you do a line in this area, this is the region for McBurney. Now, origin of celiac trunk. Origin of celiac trunk, superior mesenteric artery, inferior mesenteric artery. Here are the 3 anterior division of abdominal aorta. The celiac trunk corresponds with which vertebral level?
L1.
T12. Mesenteric artery L1 and L3 level is inferior mesenteric artery. Okay. So T12 is superior celiac trunk. Okay. Now similarly transpyloric plane is L1. So I am not doing this. Similar procedure of transpyloric plane, midline slightly above this celiac trunk. Same point, midline is the L1. So that will be superior mesenteric artery. If you are below is the inferior mesenteric artery. So celiac trunk, superior mesenteric artery, inferior mesenteric artery. What you do? First thing you need to do, you need to draw the transpyloric plane, midline. That will give the three origins. The crossing of the line is the superior mesenteric artery. Slightly above is the celiac trunk. 2 fingers below is the inferior mesenteric artery. Got? This is the instrument. Now, DJ junction. Duodenojejunal, DJ, you call it DJ Flexure. Duodenojejunal Flexure. Okay? So also, similarly, how to draw it? Pyloric Orifice. Pyloric Orifice. What are the points of Pyloric Orifice? Can you remember? Huh? Transpyloric plane.
Right side.
Okay. Slightly to the left side.
Right side.
Oh, sorry, right side. Right side of the midline. Okay. So slightly more or less in this region you mark duodenojejunal flexure. Not so exact one. Okay. So it will be always on the right side. Transpyloric plane slightly to the right. Inguinal ring and that is important. Inguinal ring is important. Now, anterior superior iliac spine symphysis previous or pubic tubercle. How will do this? Now, these things will be not be easy. So, just put the anterior superior iliac spine, put a point in the middle line, the symphysis previous. Do like this. Just assuming you are doing like this way, this is the anterior superior iliac spine. Then over here, this is the symphysis pubis, and there is the pubic tubercle, something lateral. Okay. Now, what is the deep inguinal? Deep inguinal ring is happens just above the mid inguinal point. But what is the difference between mid inguinal point and midpoint of inguinal ligament? First point is same. The second point is either it will be the upper border of symphysis pubis, or it may be to the pubic tubercle. So, if it is the upper border of the symphysis pubis, this is midpoint is mid-inguinal point. Are you getting it? One thing is anterior superior iliac spine is common in all both the cases, but mid-inguinal point it is upper margin of the symphysis pubis, but midpoint of inguinal ligament is ASIS pubic tubercle. Okay, so the first thing will be over here, and the pubic tubercle will be slightly lateral to. Okay, now 1 centimeter happens slightly above, so more or less this is the midpoint, slightly above. Okay. Slightly above is the deep ring. So if you draw a line, the point is that whether you are drawing the line is important. The second thing is that whether you are putting the point above the line or below the line. Many students are putting the point, the inguinal point ring below this point, because that is the wrong thing. You should keep your point above this line. This deep inguinal ring right above the midpoint mid-inguinal point. Okay. Now superficial inguinal ring. What is actually what they leave it? Not possible. Leave it. Fundus of the stomach, that will also not be. Maybe this is the thing that can be given. curvature of stomach. This is for lines. Lesser curvature of stomach. So very easy to know. For lesser curvature, you have to know 2 points. First is cardiac orifice. The second is pyloric orifice. The teacher will see whether you are counting for cardiac orifice. You are counting the leaves like this way to the which means 7 feet. Like these 2 lines. For pyloric orifice is transpyloric plane, slightly to the right. Then you draw a J-shaped line. Okay, so for lesser curvature of stomach, the 2 points is necessary, that is cardiac orifice and pyloric orifice. If you don't know the point of cardiac orifice and pyloric orifice, you cannot do the lesser curvature of stomach. Yeah, so this is important. Inferior border of labrum. This is a quite big one, but this is also important. Inferior border of labrum, which is also carrying a number of points.
Deep deepen.
Deep intercostal space.
Not deep mid clavicular.
Okay, happens to the mid-clavicle. So similarly, I will do the counting of leaves. I will do 5th one. So this is the 2nd, 3rd, 4th, 5th. So slightly to the in this region. No. So I will give a point. So the technique should be like this. The sternal angle, 2nd rib, 3rd, 4th, 5th. In the mid-clavicular line, slightly in this region. Okay? So this corresponds to RSDs. Okay? Now again is the 8th rib. So it is 5. So 6th, 7th, 8th. More or less like this region, vertically downwards. Okay. Coming vertically downwards, like that. The transpyloric plane, the same. Transpyloric plane. So this is the transpyloric plane. More or less this is the transpyloric plane. Okay. So what are the other 2 points? Lateral border of rectus abdominis, and the last one is 10th costal cartilage. Okay. So how to know the rectus abdominis? My 4 fingers will do the rectus abdominis. Same way. Okay, so this is the rectus abdominis muscle. My 4 fingers will do the rectus abdominis. Same line, same transpyloric plane. And 10th rib, just nothing. Put a point in this costal margin. In the costal margin, just put a point. So the first point is apex rib. Second one is the 9 centimeter away. Third one is in the transpyloric midline. Rectus abdominis muscle, right side, lateral border, close to the 10th rib. Now, so this is the inferior border of the rib, and this is very important. All the points you have to remember. Okay. So this is the point for. Now, root of mesentery. Like, this is also important. Root of mesentery is important. Why? Because like lesser curvature of the stomach, this root of mesentery, we have to know again 2 things. Okay? Junction of the transtubercular plane and the right lateral plane is the iliacal junction. And what is the other end? Other end is the Duodenojejunal region. So for DJ flexure, what you do? Transpyloric plane slightly to the right. Okay? So what we need to do first thing, this is the transpyloric plane. Okay? So close to duodenojejunal junction, it will be slightly in this region. Okay? DJ junction will be over here. Next is ileocecal. For ileocecal, what I need to do? I need to do the transtubercular plane. Like this I am doing the transtubercular plane. And again, the mid-clavicular line. So this point, so the root of mesentery, how I will draw? I will draw from this point to this point. Slightly left. Slightly to the left. So in this transpyloric plane, slightly to the left. Okay, thank you. That was a mistake. Slightly to the left. So this is the digit flexion, and this is the so don't commit mistakes like me in examination. Try to be perfect. Mistakes happens, but don't try to commit the mistakes. Because right and left, all these things matter. So digit flexion obviously on the left side, and this one on the right side. So this line is the root of the mesentery. Okay? After completing all the things, you can graph the rest of the lines to show that this is the root of the mesentery. Okay. The last one, kidney from where? Kidney from where is very, very important. So for this, we have to know again the highest point of the iliac crest. So the highest point of the iliac crest is
review.
okay. So this is which vertebral level?
L4.
L4. So L4 is this spine. Now we tell the patient to spine flex. Why? To make the spines prominent. Okay? So this is L4.
L3.
L3. This is L3. Therefore, the next spine I can feel is the L3, then L2, L1. So this one corresponds with spine, spinal cord. T12, T11. Yes. So this is T11, this is L3. Okay? Now, my both the kidneys are at more or less at this level. Okay, so the kidney more or less lies at this level. The right one slightly lower than the left one. Okay? So what will be the exact location? How much is the distance varying getting? See, two vertical lines, one is 1 inch, one is 10 centimeter. So 1 inch means close to 2 fingers. So this is 1 finger. This is the first vertical line. Okay? 2.5 centimeter is my 2 finger. Another one on this side. Over here. Okay, you can apply scale also, no problem. Another one 10 centimeter, you get a scale to measure the 10 centimeter, more or less, just measurement, approx measurement, 10 centimeter. Okay, so the quadrilateral thing you are getting is having a special name. And the name is given, what is parallelogram? Okay, So this is called Morris parallelogram, where my two kidneys are exactly located. Okay. The right one slightly lower, left one slightly at the higher level. Now what I will do? I will simply draw kidney in this region. So hilum will be on which side? This side or on the other side? This side is the hilum. So I will be more or less in this parallelogram and kidney. Just to draw. This is the hilum and this is the bone. Okay, so right or left kidney, you can do it in this way. So kidney, all these lines which I have shown is important. Morris parallelogram is required. Drawing of the highest point of iliac crest L4. Flex the patient a little bit to more appropriate the spines. Okay, so you see if we do any spinal procedures, we flex the patient. The knee is going to the abdomen, the elbow or the thing is going like this. This is the total flexed posture where the spine is getting more and more prominent. Okay, so all these steps that examiner will see whether you are following the steps. You are drawing the highest point of iliac crest or not. You are telling the patient to flex. Then you are counting the ribs. Okay, you are keeping a point over here for L3, counting for T11. Just putting 2.5 centimeter for one vertical line, more or less 10 centimeter for another vertical line. We got two parallelograms and we draw kidney shape. Okay, so this is how we can draw the kidney. So this is what we have in our surface.